Bismillah ar-Rahman ar-Rahim. We shall start the second term in orthopedic study, and we starting by general orthopedic lectures. And first of those groups of lectures is osteoarthritis. The anatomy of the and physiology of any side of the joint. Here you can see the articular surface. Some joints contain menisci, fibrocartilage parts, or space fillers, with the synovial fluid in between these joints as a lubricant materials, surrounded by a capsule. This is diarthrodal joint, which is commonly vulnerable to the OA changes or what's called osteoarthritis. You can define the osteoarthritis. It is a degenerative process with the reparative process at the same time. That means the two pathological conditions going side by side. In some area there is a degenerative process and disruption, and the other parts of the joint there is a reparative process. And here the composition of the articular cartilage. You see the chondrocyte cells synthesis collagen fibers, which form the structural frameworks, and hydrophilic proteoglycans, which is interact with the collagen fibers to form hydrated macromolecular matrix of the articular cartilage. This, you see it, spongy material. You see here the structures, the truss structures of the collagen fibers, and how the pressure affects it, and how resistance of the substance, and diffusion of the fluid and water inside the materials in the compression, and here squeeze the water and decrease and deform the shape and size of the articular cartilage as a shock absorbent substance. And here you can see the structure of articular cartilage, and underneath it there is a bone, like a mattress of sponge on a frame of the wood, like a bed of sleeping. You see here the spongy materials, and here the hard structures, subchondral bone and trabeculae of the bone. Osteoarthritis articular cartilage has a matrix which consists of the proteoglycan ground substance that contain collagen, mainly type 2, a network, and chondrocyte. It has a compressibility and elasticity to make the joint movement easier, and fibrillations of the articular cartilage after trauma or inflammation will occur usually. Definition of osteoarthritis: it is a chronic joint disorder in which there is a progressive softening and disintegrations of the articular cartilage, accompanied by new growth of the cartilage and bones at the joint margins and capsular fibrosis. So it is two processes going by side. It is a degenerative process at one hand, and at the other hand there is a new growth and reparative process. Reparative process with disruptive and degenerative process at the same time. Also, there are sometimes a local sign of inflammation, and it is not primarily an inflammatory disorder. Even it is called osteoarthritis, ITS, mean inflammation, but it is not an inflammatory process. So it is a dynamic process, destruction and repair. Etiology of osteoarthritis: age process. Aging of the cartilage shows diminition of the cellularity, reduced proteoglycan concentration, loss of the elasticity, decrease in the breaking strength. Note, these changes are restricted to the certain joint and to specific area of the joint. while other areas shows little or no progression with the age. That deformities and fracture can initiate OA changes in an unusual joint for primary OA changes, like the ankle and the elbow. These joints, we can say they are immunized from primary OA changes. Unless sustained trauma, they are unlikely to develop primary OA changes. Continue about the etiology. Primary changes in the cartilage matrix, like a crystal deposit disease and genetic defect in the type 2 collagen fibers, might be disposed to the OA changes. Precious inflammatory disorder, this might cause articular cartilage damage, and the enzyme that released by synovial cells and leukocytes can affect proteoglycan. Example, secondary OA changes can occur in a patient with rheumatoid arthritis. Increased mechanical stress with the joint overloading is the major factor, and this can be due to, first of all, increased load in the deformity and instability. Changes in the subchondral bone can change the shape of the articular cartilage or can reduce the shock absorbing effect of the supporting cancellous bones by increasing bone density. So the OA changes go with increased bone density, and it is less affecting the joint with the osteoporosis. Here the box about the etiology of the OA changes. Systemic predisposing factors. These are genetic factor, age, gender, and diet and obesity. Local biomechanical factors, abnormal joint shape and size can causing OA changes. Previous injuries, neuromuscular problems, obesity also can causing local effects, and loading occupational factors, bone mineral density. It is unclear whether this is a local or systemic factor, but anyhow, the soft bone reduce the incidence of OA changes. Pathogenesis. The earliest changes are an increase in the water content of the articular cartilage and easier extractability of the matrix proteoglycan. This is due to the failure of the internal collagen network that normally restrain the matrix gel. At a slightly later stage, there is a loss of the proteoglycan and defect appears in the cartilage. As the cartilage becomes less stiff, secondary damage to the chondrocyte may cause release of the cellular enzyme and further matrix breakdowns. When the articular cartilage loses its integrity, there will be a more force on the subchondral bone, and so there will be a trabecular degenerations and cyst formation in the subchondral bone. And there will be increased vascularity and reactive sclerosis in the zone of the maximum loading. The cartilage at the edge of the joint still has activities of growth and enchondral ossification, giving rise to the osteophyte formation. So this is the process of osteophyte formation. Usually, as we mentioned later on, in the X-ray, we see an osteophyte. Here, the pathological condition causing the osteophyte. Take care about this note, is important note. The radiological features of OA changes, and in comparison with the radiological finding, focal areas of loss of articular cartilage, the joint space narrowed if loss is extensive. Bone growth at the joint margin causing, and on X-ray causing osteophyte formation or appearance. Sclerosis of the underlying bone, sclerosis or subchondral bone formations, or sclerosis. Cyst formation in the underlying bone, bone cyst appears on the X-ray. Loss of the bone adhesions. Varying degrees of synovial inflammation, effusion may be apparent as a widening of joint space in some area, or there may be cyst formations around the joint. Fibrosis and thickening of the joint capsule not visible on the radiographs. Here you see the surface of the articular cartilage like it is hidden by a pump. and there is destruction on surface with the fibrillation of the articular cartilage, superficial fissuring, and by time it will lead to the extrusion of the fluid to inside the subchondral bone, lead to the cyst formation here, and so on, the pathological process going on. Here, advanced OA changes lead to the destruction of the articular cartilage and exposure of subchondral bone. Here, subchondral bone eroded, and narrowing of joint space. You see it. Advanced degenerative changes. The articular cartilage lost, and the joint space is narrowed, severely narrowed, and showing remodeling osteophyte and subchondral cyst formations. Here, subchondral cyst formations because of pressure of the fluid press or diffuse inside the bone. And here there is subchondral sclerosis due to the pressure effect. There is no shock absorption effect of the articular cartilage. Direct pressure on the subchondral bone leading to the sclerosis of the bone. Here, the microscopical pictures are the new vascularity, vascular cyst formation here, and here in the high power views, you see the articular cartilage shows loss of the metachromasia and deep cleft in the surface fibrillations. Attempt repair result in the subarticular sclerosis and buds of the fibrocartilaginous mushroom-shaped formations. Here, mushroom shape is osteophyte. Okay. Prevalence. It is the commonest disease among all the joint disease. Prevalence of the OA changes is the commonest disease of the joint. The autopsy studies shows the OA changes in everyone over the age of 65 years. And men and women are equally affected, but more joint affected in the women than in the men. But usually they are affected equally. But in the women, the more joint, not percentage, why, but number of the joint in the same patient. OA changes are much more common in the some joint, the finger, hip, knee, and spine, than in the others, elbow, wrist, and ankle. It means the joint those vulnerable to the more stress. And this is because some joints are more prone to the predisposing factor than the others. Geographic distribution is very low incidence, virtually absence of the hip OA changes in the South Chinese and African blacks, and this is related to the low incidence of the predisposing factors. The evidence less incidence of the DDH or Verti's disease in this population. In our society, we have a high incidence of OA changes involving the joint because of the social habit of our society. We are sitting on the ground in crawling position, while the hip joint is less affected. The hip joint, and this is differs from the Western countries where they have high incidence of OA changes involving the hip joint because they are wheelchair habit of the life and the more stress to the hip joint rather than the knee joint. Clinical features. The patient usually in the middle and over of age, and the pain is the usual predisposing symptoms or presenting symptoms. It is often widespread or may be referred to the distal side. Pain in the joint may be due to the OA changes of the hip joint. Stiffness is the common. It occurs after a period of inactivities, but with the time it becomes constant and progressive. Usually, after sleeping and get up from the bed, a patient complains from stiffness, while it becomes more progressive and constant by time. Swelling may be intermittent, suggesting of an effusion, or continuous with a capsular thickening and large osteophyte formation, where the joint becomes thick and deformed sometimes. Deformity, it may be predisposing to the factors, and it is at 15 times as a result of the clinical progression of the joint or changes. Loss of the function and activities, limping, difficult handling, and handwriting, and so on. The other extra factors. Fatigability and sleep disturbance and depression. Also, this patient complained that he had wasting of the muscle and inability to do his usual activities, and there may be a crepitus due to the osteophyte. We hear some sort of the sound crepitus, like a fracture crepitus in the joint. Here, an osteophyte of the distal interphalangeal joint, or changes. Those, especially in the lady, what's called Heberden nodules. So, as you know in the medicine, it's called Heberden nodules, or changes of the distal interphalangeal joint, commonly in the old ladies. By X-ray, in the wet palm joint, we should be in a standing position, and it will show decreased joint space, subcondylar cyst formation, subcondylar sclerosis, chondrocalcinosis may be found, and osteophyte formations. By arthroscopy, may show cartilage damage long before the X-ray changes appears. Complication: capsular herniations of the posterior capsule, like in the knee joint, was called Baker cyst. Loose bodies, rotator cuff dysfunctions in the shoulder joint, spinal stenosis in the or changes involving the synovial joint of the lateral masses of the facet joint. The facet joint involved because it's synovial joint, facet joint of the spine, so that this is liable for osteophyte formation and impingement of the intraspinal content, leading to the spinal canal stenosis. Spondylolisthesis due to the facet joint osteoarthritis, especially L4, L5 facet joint, lead to some instability of the spine and backwards movement of the vertebra above on the vertebra below, what's called retrolisthesis. Retrolisthesis. Here, paragraph showing the radiological features of osteoarthritis and the osteoarthritic symptoms. Here, the schedule of management. Here, a large number of patients presented, some of them just by education, decrease the weight loss, exercise, lifestyle change, decrease the number of the patient, and self-helping, simple analgesic, topical agent, lifestyle changes like using of walking stick and so on, and some medication like the food supplement medications, and then go to the severe groups. Simple non-surgical interventions, non-steroid anti-inflammatory drugs, physiotherapy, occupational therapy, orthosis, and aids. Some aids like the weight-bearing sticks and so on. Advanced or changes non-surgical intervention injections, what we call sometimes use steroid or spacing agent like hyaluronic acid. Plasma can also play some role in the OA change management, and those with the more severe, and they are few patients. I mean, big number of the patient. Suppose we take about 100 patients. This is decreased to about 15 patients from this 100 or 20 patients. Remains those with the advanced OA changes or severe OA changes may need partial or total joint replacement and surgery for joint preserving osteotomy or resurfacing surgery. This is the schedule of the OA changes management.